Hey guys, thank you, Dr. Kip, for the warm introduction, and thank you all for being here today, despite being the last day of the academic year, and for giving me this platform to share two things that I'm truly passionate about, neuroimmunology and global health. And for those of you who have not had a chance to meet, my name is Nate. I'm one of the third-year residents here at Stanford. Given that this is my first big talk here at Stanford too, I decided to wear the same tie that I wore for the residency interview 4 years ago. So that's my fun fact that no one had to know, but I just felt like sharing today. But what I'm even more excited to share about today are the 4 wonderful mentors that I've met throughout my residency training, who are truly pioneers and trailblazers when it comes to global neurology and neuroimmunology. They're role models I look up to and want to emulate in my future career. So I hope you all find this talk, and more so the Q&A session, informative and interesting as much as I do. And my talk today is titled Global Health and Neuroimmunology, Breaking Global Barriers. I have no financial disclosures today. And jumping into the talk, this will be the outline of my presentation today. First, I would like to introduce our 4 wonderful neuroimmunologists as our panelists. I wanted to do this first because many of the papers that I'll cite throughout my talk today were written by them. So I thought it would be helpful to have that context, hopefully making it more engaging for the audience as well. Then I will review some relevant background information, followed by motivation for research questions and projects moving forward, followed by the most important section, Q&A, leading time for questions from the audience as well. So jumping into panelist introduction. First, we have Dr. Farah Mateen, who is joining us from Boston today, who is one of the leading experts in the field of global health. Dr. Mateen completed her neurology residency at the Mayo Clinic in Minnesota, followed by fellowship in medical ethics at Harvard, and a second fellowship in neuroimmunology and neurological infections at Johns Hopkins. She completed her PhD in international health at Hopkins as well. She's currently an associate professor of neurology at Harvard Medical School and also serves as the associate director of the MS and NMO unit at MGH. She also leads multiple projects, including Guinea Epilepsy Project, which is a multi-country study of smartphone-based EEG, and in other countries, as well as Tanzania and Bhutan. She previously served as the chair of the American Academy of Neurology Global Health Section and Ethics Section, and also has worked with the UN High Commissioner for Refugees, WHO, and other NGOs. And as an intern, on a personal side, I also had the privilege of going to Guinea with Dr. Mateen back in 2022, some pictures included here, where we worked with local neurologist residents and attended to over 400 patients with and without epilepsy. So thank you for being here, Dr. Mateen. Our next panelist is a true champion of social determinants of health. And Dr. Liliana Amezcua is joining us from Southern California, and she completed her neurology residency and neuroimmunology fellowship at University of Southern California. She's currently an associate professor of neurology at USC and serves as a director of neuroimmunology fellowship. She also serves as the principal investigator for many important research projects, including a consortium called the Alliance for Research in Hispanic MS, focusing on better defining racial and ethnic health disparities by examining modifiable factors, including social and environmental determinants of health. She also serves in numerous committees, including National MS Society Medical Advisory Committee, AAN Quality Measures of MS Committee, and NINDS Health Disparities Strategic Steering Committee. Thank you, Dr. Amezcua, for being here. Our next panelist is Dr. Monica Diaz. Dr. Diaz completed her neurology residency at Yale and fellowship in neuroimmunology and neurological infections at UCSD, followed by the NIH Fogarty Global Health Fellowship in Lima, Peru. She's currently an assistant professor of neurology in the Division of MS and Neuroimmunology at the University of North Carolina at Chapel Hill School of Medicine. She also serves as a co-director of the Global Health Neurology Elective Rotation, facilitating bilateral neurology resident rotation between UNC and Universidad Peruana Cayetano Heredia in Lima, Peru, and serves as a vice chair of the AAN Global Health Section. Her research interests include cognitive impairment in people living with HIV or following the COVID-19 infection, particularly in Latin America and among Latinos living in the US, as well as investigating the burden of Alzheimer's and related diseases in international settings. Thank you, Dr. Diaz, for being here. And last but not least, we have Dr. Deanna Saylor joining us from Lusaka, Zambia. Dr. Saylor completed her neurology residency and fellowship in neuroimmunology and neurological infections at Johns Hopkins. Her interests include neurological complications of HIV, as well as neurologic disease burden in resource-limited settings. Her interest sparked when she did a 6-week rotation at a rural Kenyan hospital back in 2010. And after her fellowship, she moved to Zambia in 2018 with her family to develop a neurology program. She's now helping Zambia-trained neurologists start their practices independently and at the hospital. She is also the recipient of the 2022 Hopkins Medicine Alumni Association Global Achievement Award. On a personal note, I will also have the privilege of rotating in Lusaka this August and September for 6 weeks under Dr. Saylor's mentorship. And thank you, Dr. Saylor, for being here today, despite the time difference. And as you can see, we have an amazing group of panelists joining us for our talk today from all over the world. So I hope you're all excited as much as I am today. So, and with this, I'll jump into a quick summary of some of the background information and their significance that paves our motivation for further studies and questions to be asked and answered from both a clinical and research perspective. And as many of you have figured from the title of the talk and the profiles of our panelists, the disorder of interest for today's talk is multiple sclerosis. And as we all know, MS is considered one of the quintessential inflammatory demyelinating disorders of the central nervous system. MS is becoming more and more prevalent, and there are about 200 new diagnosed cases made in the US alone every week. And although the diagnosis of MS has been increasing, the pathobiology or the pathogenesis of the disorder or how lesions develop remain imperfectly understood and characterized. And this remains a challenge in terms of research and therapeutic options. We currently have more than 24 FDA-approved medications in the US for MS itself, and the introduction of monoclonal antibodies such as ocrelizumab and natalizumab have really changed the paradigm of how we think about the disease and manage the disorder. Undoubtedly, this is one of the most exciting eras of MS therapeutics. However, even in high resource settings, such as in the US, more than 1/4 of the patients will eventually need wheelchairs 20 years after the initial diagnosis. The truth is that there's no definitive cure for MS or anything that reverses the disorder, which leaves us with more desire to better understand the disease, the pathobiology, to ultimately better serve the patients. Although MS does affect certain demographics more than others, the truth is that MS affects everyone and anyone. I think in med school, we're taught and we thought and we were taught that MS most commonly affects young Caucasian female patients, as we commonly see in our vignettes and our clinical questions that we have to answer. However, an interesting study actually from 2008 from Norway actually revealed that certain immigrant population originating from other continents, especially in Asia, actually had higher prevalence than patients with Scandinavian ancestry. There are many recent and crucial and relevant epidemiologic studies and publications, including one published last year by Mike Hiddle, listed here. He's actually a PhD candidate here at Stanford. Came out to better understand and characterize the patient population with MS. And like-minded neuroimmunologists, such as our panelists today, started delving into the underlying racial and ethnic disparities, as well as intersections with social determinants of health and implications of health outcomes for patients in hopes of identifying and rectifying these barriers. So what actually makes MS a disease of interest and of relevance when it comes to diagnostic and therapeutic challenges that are influenced by multiple factors that I just listed, including socioeconomic, racial and ethnic and epidemiologic factors? I think the undeniable fact is that MS is an extremely dynamic disease when it comes to spatial and temporal dynamics. And as you can see on the right side, we have a series of in vivo MRI, which is a T1 weighted post-GAD image taken over 20 years of a single patient, taken every 1 to 3 months. This was a patient with MS who had a longitudinal relationship with the translational neuroradiology section at the NIH, led by Dr. Denny Reich, as Dr. Kip introduced earlier, who truly embodied the definition of being partners in research with clinicians and clinician scientists. You can see that many lesions pop up, as highlighted by the hyperintense foci that appear, but also many lesions disappear and become iso-intense, and they have different phenotypes based on the age of the lesions. Some lesions remain somewhat iso-intense, as you can see, whereas some become perpetually hypo-intense, often referred to as the T1 black hole lesions. Similarly, on the left panel, we can see a same dynamic nature is recapitulated in a non-human primate model of MS. Specifically, this is the marmoset experimental autoimmune encephalitis or encephalomyelitis, or in short, EAE model that we also investigated at the NIH. The nature of the MR sequence here is a little different in that it is a T2-based proton density weighted sequence without gadolinium, but I think it recapitulates the dynamic nature quite well. So in summary, the spatio-temporally dynamic nature adds to the challenge of accurately diagnosing MS. I think to make things even more complicated and challenging, there are multiple types of MS. And I would argue that many neuroimmunologists would agree, and this is not an exaggeration to say that MS probably is an amalgamation of different diseases that share a common denominator of having inflammatory demyelination in the central nervous system. MS itself is very diverse. First, there are different categorizations of MS, as we all know, based on their clinical trajectory. As you can see on this graphic, for example, the relapse-remitting MS, where patients have alternating periods of relapses and remissions. SPMS, or secondary progressive MS, with more gradual progression intertwined in between. And primary progressive MS without clear relapse and remitting temporal association. Now we're learning more about the conditions like radiologically isolated or clinically isolated syndromes in which one may turn into another, as we all know. But this heterogeneity overall also adds to the diagnostic challenges of MS, in that one individual with MS can vastly differ from another person with MS. Not only are the forms of the disease and the time course of the disease progression different, but the lesions themselves in multiple sclerosis are extremely diverse. There was a time, I think, that MS was described as a primarily demyelinating disease of the white matter, but with postmortem studies and higher resolution MRI that allows cortical imaging, we all know that this is not the case anymore. MS lesions can exist in pretty much any location in the central nervous system, including subpial layer, cortical layer, juxtacortical distribution, periventricular, spinal cord, brainstem, et cetera, et cetera. Furthermore, based on the age and the activity of the lesion, their immunologic profile can evolve and change over time. For instance, looking at the middle panel here in the figure, which is a figure derived from one of my favorite review papers on MS, you can see that acute white matter lesions have a robust activation of both the innate and adaptive immune system. Once the lesions become somewhat chronic, they can further take different paths of fate. So for example, on the top panel on the right side, they can become what's described as smoldering or chronically active and inflammatory lesions. And the middle panel, you also see that they can also become chronic inactive lesions after losing all the myelin in the area of damage and turning into a state of gliosis, if I may. Or ideally, they can go into a repair mode and become remyelinated. And what exactly drives these different paths is still yet to be discovered, and perhaps one of the most exciting research questions being asked by many investigators around the world. So with all the combination and permutations of the previous three slides, I think we can all appreciate that the symptomatologies of patients with MS can almost be any and every symptom we've seen as neurologists and trainees. So this figure from the same review paper highlights the diversity of MS lesion location, including the spinal cord, which we have barely talked about, as well as different parts of the neuroaxis. Symptoms can range from optic neuritis, hemiplegia, spasticity, bowel and bladder incontinence, and gait abnormalities, etc. In addition, there are other factors that contribute to the challenging nature of diagnosing MS, given that MS does not have a definitive pathognomonic biomarker in the serum or the CSF, at least not yet. There are many markers being investigated, for example, the neurofilaments, and some may argue MR findings themselves can be considered biomarkers, which we'll discuss further. Given this diagnostic challenge, the first McDonald criteria was actually created back in 2001 by neurologist Ian McDonald, with the National MS Society of America and other international panels focusing on what's called the Poser criteria. I think we commonly know this as dissemination in time and dissemination in space. Then it was updated again in 2005, again in 2010, followed by the most recent version in 2017. This updated version did certainly help with expedited diagnosis from an average of 13 months of diagnosis from first symptom onset using the 2010 criteria, to 3.2 months from initial symptom onset. However, when they extrapolate and were only using clinical events as a sole basis of diagnosis, it took over 4 years. I think this highlights the reality that even with the updated diagnostic criteria and a better understanding of the disease and how things progress or not progress, timely diagnosis of MS does rely a lot on many neurodiagnostic tools, including MR imaging, as well as CSF analysis, which, as you can see, is only sparsely available. In the bottom, you see that in low-income countries, per the 2015 survey, only the top 10 to 20% of socioeconomic class could access such diagnostic tools, making it a very limited resource. And this is just a quick recap of what the actual 2017 McDonald criteria states. The texts are quite small, but I'm sure most people in the room already know this. But my favorite part about this chart is that, as Dr. Kip always reminds us residents and teaches the rotating medical students, diagnosis of MS is clinical. So the first two criteria highlighted by the red box here actually indicate that you do not need any MR imaging or CSF analysis to make a diagnosis of MS. The truth, however, is that in our current practice, we do rely a lot on these diagnostic tools, as many of the symptoms, as I mentioned already, can be very non-specific and not so easily quantifiable with markers like biomarkers in the serum or CSF. Just to add a few more flavors of the McDonald criteria and maybe perhaps a potential future of it, at ACTRIMS this year, which is the biggest MS conference in the world, I believe, it was discussed that an updated version of the McDonald criteria might be out soon, sometime in the next year or so, possibly including new MR biomarkers. Some candidates include the central vein sign, as illustrated on the left figure, where the center of the lesion has a hypointense signal associated with enlarged vessel visible on either T2 star or even flare star sequences, which has been demonstrated to be very specific to MS lesions when compared to other disorders in the central nervous system that may have a similar ovoid-shaped T2 hyperintense lesions like migraines or SUSACs. Or they could also consider including something like paramagnetic rim lesions, as seen on the right panel here, where chronic active lesions may show paramagnetic iron deposition at the rim of the lesion, highlighted by the rim of hypointense signals on the unwrapped phase imaging here. That beautifully co-localizes with active inflammatory demyelination on postmortem data where there's iron-laden macrophages. However, these are all exciting updates, but I think it's important for us to remind ourselves that these may not necessarily help the diagnostic challenges that I just explained, experienced in low resource settings, especially since most of these sequences do require relatively high power magnets, or at least the diagnostic yield increases with high power magnets, for example, 7 Tesla versus 3.3 or 3 versus 1.5. And it also requires some post-processing, like unwrapping the phase image or combining the T2 star with flare to create a flare star. And the more we learn about MS as a disease, we're learning as a field that the disease is extremely common yet understudied. It is the most common inflammatory neurological disorder in young adults and affecting about 3 million individuals worldwide, and the number keeps growing every year. It is also one of the most common causes of non-traumatic causes of disability among young adults. And as we mentioned previously, the range of symptoms can be extremely vast, as it can affect any part of the CNS. In many global reports, including the widely used epidemiologic publication by Dr. Mitch Wallin, here included in the middle section from Maryland, there's increasing prevalence of the disease, which the diagnosis has increased more than 10% in the past 1.5 decades. However, there still exists a great amount of paucity of data in many regions of the world using these global reports. For example, this report did not include data from Asia or other parts of the world as listed here. This makes us wonder there are probably many undiagnosed or even misdiagnosed cases of MS that are not adequately addressed or treated. I think it's important for us to also not forget that many social factors impact MS diagnosis and outcomes. On the right of this slide is a diagram from the WHO website highlighting the different social determinants of health that play significant roles in one's health, including food security, access to transportation, housing, financial burdens, and education that we often, as physicians, don't really think about when we interact with patients. And of recent, a great number of publications have actually come out in the realm of MS, highlighting the potential impacts of health disparities in MS patient population in the States, including these papers by our panelists. And a special shout out to the third paper here, written by Nuriel, who is actually one of our Stanford Neurology graduates working with Dr. Amezcua. So delving deeper into some of the literature in social determinants of health, it is not surprising, unfortunately, to find out that such health disparities, unfortunately, do exist in the United States. For example, some of the papers highlighted here revealed that health disparities associated with patient ethnicity, race, led to worse clinical outcomes. There were greater health disparities also found for those with lower income, lower levels of education, and lower health literacy. And these disparities also exist in our global community. For example, this beautiful manuscript written by Dr. Diaz's group about neurologic health disparities in Peru discussed that less than 70% of patients initially diagnosed with MS actually received disease-modifying therapies. In another study by a neuroimmunology group in Buenos Aires, they identified that in 12 Latin American countries, patients with MS who did not have access to DMTs were more likely to have public insurance compared to private insurance, have lower levels of education, more likely to be unemployed, and also have longer duration of the disease and accumulation of the disability from it. In another study investigating NMO patient population in Latin American countries, it shows that in low to middle income countries, less than 10% of the patients could actually afford treatments, including DMTs, yet alone things like steroids or IVIG. And everything sounds very depressing, but on a bright light, and due to the clinician advocates and investigators like our panelists here today, equitable access to MS treatment is actually receiving more attention and traction, as highlighted by the WHO's statement earlier this year, which was later published in Lancet Neurology, stating that MS treatment is considered essential. And one may say that this may seem like a small step, but I do believe that recognizing that there is a problem is the first step of solving one. And with this background, thinking of global MS population, a concerted effort was made to identify what are the global barriers to diagnosis of MS. So this 2023 study, a really beautiful study done by Andrew Solomon from Vermont, coordinated information from over 107 countries, including the highlighted countries on the map here in orange. Here, the authors actually reviewed the current practice and barriers of diagnosing MS, both from a physician perspective, but also from patient's perspective. And it actually identified that more than 88 countries, or 80% of the countries surveyed, identified at least one major barrier to timely diagnosis of MS. Most centers were using the updated McDonald criteria from 2017. So looking into this, what were the actual barriers? And this is what the first figure shows, in that the most common was actually the lack of awareness of MS symptoms among the general public, reported by patients themselves. Second most common was the lack of awareness of MS symptoms among healthcare professionals. Third was unavailability of healthcare professionals, period. And it is also notable that number 4 and number 5 highlight the costs and availabilities associated with access to diagnostic tests, which again brings us back to the idea of accessibility in low resource settings and social determinants of health. And only 16% of patients indicated that there was no major barrier to timely diagnosis of MS. So by this point of the talk, I think I've talked enough. I hope I have fully convinced you all of the following things. One is timely and accurate diagnosis of MS is difficult, given all the multiple variables, including the dynamic nature of the disease, and also the intimately intertwined relationship between social determinants of health, such as accessibility to appropriate healthcare resources. And with this, now I would like to briefly talk about my motivation and future directions before we jump into the Q&A panel with session with our panelists. So with all this background, one may ask, does diagnosing MS really matter, or a timely diagnosis matter? So I think before we jump into data, we can also just think about it conceptually, that when you diagnose someone and someone does get DMTs, we have to understand that DMTs are not harmless. I think we all know this, but they can also be quite costly. And if you think about all the opportunistic infections that we screen for, such as JCPML, committing to DMTs is not something to be taken lightly. It's taking many hours of your life committing to treatments. And I think accurate and precise diagnosis also avoids both unnecessary over and under medicalization of patients. And of course, providing accurate medical diagnosis, I believe, is just the right thing to do for our patients when it comes to the theme of justice of practicing medicine. So the other truth is accurate diagnosis can lead to timely treatment. And does it matter? The long story short is, yes, it does. There are a great number of studies that demonstrate that early start of DMTs is associated with improved clinical outcomes, reduction in healthcare associated costs, and reduction in disability adjusted life years. And not to derail too much from the talk, but also early initiation of intense DMTs, such as ocrelizumab, has also been shown to have decreased sustained accumulation of disability, or here labeled as SAD on the graph on the y-axis, compared to escalation, or also known as step therapy, where they start with a less potent DMT and moving upwards, as highlighted by the JAMA Neurology paper here. So what's next? With these in mind, one of the projects that I will be working on as part of the neuroscience scholars track here at Stanford, I'll be investigating the impact of social determinants of health on time to diagnosis for patients with MS here, including demographic factors such as ethnicity, race, age, insurance status, sex, zip code, primary language, and other factors involved. So with this, I also aim to investigate whether such difference in demographics will also lead to difference in clinical outcomes, hopefully in a quantifiable way, mainly using the metrics such as the icometrics dataset for MR volumetric analysis. And if time permits, we also aim to investigate the impact of social determinants of health in our community hospital patient population, where all the residents rotate down in Santa Clara Valley Medical Center. And last but not least, in a few months, I'll be in Zambia for 6 weeks, working with the neurology group at the University Teaching Hospital under the mentorship of Dr. Deanna Saylor. I would just like to take this moment to thank both the NST committee, specifically Dr. Brenda Porter, who's here, for supporting this project, my mentors, Dr. Kip and Dr. Lori Nelson, and also Dr. Vora, our program director, who has been an avid supporter of my passion for global health and my academic pursuits. So now, I know that I ended it a little earlier than the typical Q&A, but when discussing the potential questions with the panelists, I think we all agreed that we'll need more than 30 minutes. So forgive me for cutting it a little short. But now on to the most important part of today's grand rounds, which is the Q&A. I prepared a few questions for our wonderful panelists with Dr. Kip, but also wanted to leave enough time for the audience to ask questions at the end. And I was also told I should ask targeted questions for 1 to 2 panelists at a time, but the truth is that I couldn't choose which panelists to ask what questions because selfishly I wanted to learn from everyone. So please forgive me for doing this. And just confirming that everyone's on. Okay, perfect, yeah. Alrighty. So the format here is I included photos of our wonderful panelists and then because I want to hear from everyone, maybe you can start from the left and go to the right. But the first question here is, throughout your training and your career, were there any seminal moments in your training or practice that really sparked your interest or solidified, especially when it comes down to global health and or health disparities? So if we may start with Dr. Amezcua and move rightward to Dr. Deanna Saylor, then that'd be great. So Dr. Amezcua.
Yeah. Thank you so much, Nate. First of all, congratulations. And I look forward to seeing your work come forward. Well, definitely, I mean, global health and health disparities have been at the forefront of everything that I've been doing. And what got me interested, it wasn't necessarily that something came and then I got interested. It was the fact that I was simply just caring for MS patients across 2 different system settings, and that was we had the private setting and then we had the LA County Hospital. And if many don't know, LA County Hospital is one of the largest safety net health systems in the United States, one of 2, and so there was differences in how we were taking care of our MS patients, what was accessible, what was available. And of course, there was also differences in the type of population I was looking at, where most, greater diversity in terms of race and ethnicity was being seen in at the LA County Hospital. And back then, not to say how long ago, but at least 15 years ago or so, it was basically, we were still talking about MS just happening in white European background. And certainly that was not what I was seeing. And just there was not enough data to support why I was seeing so many more. Was it just an issue of, the prevalence of these populations living in Los Angeles? But certainly what I was noting was that there was differences in their outcomes and then the severity, despite some observations that perhaps their MS was starting at an earlier age. So just, in that short manner, I started becoming interested in looking at MS outside of what we knew. And of course, being the proximity to Mexico, started investigating MS in that country as well, and forming collaborations.
Thank you very much. And Dr. Saylor?
First of all, thanks, Nate, for the invitation. It's great to be on this panel with these great colleagues, and congratulations to you on a great presentation and exciting work to come. For me, my first interest in global health came after a general medicine rotation in Kenya when I was a medical student. And I think what hit me was just the level of need that I saw. I thought I had seen need in inner city Baltimore, but it was just on a completely different scale. And I felt like the opportunities for impact and interventions were greater in that setting. And so that sort of started me on my global health journey. And then I think thinking about MS, it had never really made sense to me that we saw these high rates of MS in immigrant populations who happened to move to high-income countries and predominantly white countries where MS was recognized. And then working in Africa throughout my residency and just seeing the lack of access to neurological care, it only made sense to me that it wasn't that MS didn't exist in this setting, it was that neurologists didn't exist in this setting and MRIs didn't exist in this setting. And so I think I was just really inspired and motivated to try to show that when you put neurologists and MRI scans in the middle of Africa, suddenly MS appears. And so I think it was just that seeing the need and seeing the lack of access just led to motivation to try to raise awareness to how how the financial and access barriers really impact our understanding of prevalence and burden.
Thank you, Dr. Saylor. And Farah, hi.
Hi, Nate. First of all, thank you. It's great to see all of my friends and colleagues on the panel. And I was going to say, Nate, next time you have to show a photo before we get on the plane rather than after 18-hour trip. So, yeah, and I'm also looking forward to your fellowship and all the great things that are going to spawn off of hopefully today and then many years to come. But in terms of global health, I'm from Canada. Many of you know I'm from more northern Canada. So my first kind of interaction with health justice and health disparities was with what we call First Nations in Canada, or American Indians in the US. And the very stark differences in health outcomes. And honestly, when I was undergrad, I liked a lot of things. I liked anthropology and I liked geography, and I thought even about doing law instead of medicine. And then I went into medicine. I really liked it. I really liked neurology, but I didn't really see I saw the intersection of global health and global health policy and neurology, but I didn't feel like the field was there. And I also just really liked MS. We have a lot of MS in Northern Canada. I grew up with friends whose parents had MS, but I could never merge those until relatively recently. I'd say probably in the last 5 years, where MS has started to really, I think, expand its scope and think about global health. And global health has also expanded its scope and started to think about neurology and neuroscience. But really, those were two sort of separate solitudes, two loves that, over time, I was finally able to merge.
Thank you, Dr. Mateen. And Dr. Diaz, and I see that your background is Golden Gate Bridge. I don't know if you changed it for today's talk, but thank you.
I didn't. This was left over from yesterday's meetings, but coincidence. Well, thank you, Nate, for inviting me. You gave a great talk, and I'm happy to be on the panel with other friends and colleagues. So I've always been interested in global health, I guess, maybe even since undergrad. I'm from Miami, which is predominantly Spanish-speaking Latino population. So I kind of grew up seeing the disparities in my hometown. And then went on to medical school in New York City, where I was in SUNY Downstate. And, it's a very culturally diverse, predominantly immigrant patient population. So, being around these healthcare disparities, I really became interested in addressing these. And then I was always very interested in international health as well. So kind of like merging both of those interests that kind of led to my, career trajectory in global health. And then in residency, I actually did the Yale, Stanford, Johnson & Johnson Global Health Scholars Program. I actually don't know if it's still ongoing, but maybe some of you may know of it. So I had the opportunity to rotate in Makerere Hospital in Uganda for 6 weeks, both in PGY3 and PGY4 years. So it was really after that experience that I really became interested in pursuing this as a career. And that experience also let me see what a lack of neurologic diagnostics there are, and just, kind of further pursue that in my career, both in research and clinically.
I see. Yeah. Thank you all for that, answering that so thoroughly. And one of the common themes that I'm hearing is that there was accessibility issue, especially when it comes to diagnostics. So jumping into the second question, which is, in your experience in low resource settings, especially in global community, how is MS actually diagnosed? And one of my questions is, how accessible is MRI actually, or even LP? I remember two things. One is, when I was rotating in Guinea with Dr. Mateen, we were teaching the residents how to do LP, and using lidocaine was a new theme for them because of how expensive the medication was. And that's one thing I'm interested in. Second is, there's a lot of news coming out about Hyperfine, which is the portable MR that's also being piloted here at Stanford. So how do you foresee using those kinds of portable technology, like the smartphone-based EEG that Dr. Mateen used in Guinea, in future practice in these settings? So maybe we can start with Dr. Mateen.
Yeah, I think it's, well, as you know, Nate, a lot of people with MS are simply not diagnosed, just to really address that head on. They don't know they have MS, they haven't heard of MS, and they may have had either no diagnosis or a variety of misdiagnoses. And in Guinea, in West Africa, where I've been spending more of my time recently, it's very challenging to get an MRI. You can get a low Tesla MRI. They're not used to seeing MS. And so for some, for us, MS is a common diagnosis, but they're not used to seeing it. So even when it's there, it may actually be a little more challenging to separate out from other white matter conditions. Access to neurology, there's not really an MS subspecialty practice in the places I've worked in low resource settings. And so potentially somebody has gone abroad and seen MS or had an ECTRIMS training fellowship, but those are still few and far between. Hyperfine, as you mentioned, is like this portable brain MRI scanner, and it does hold promise for resource limited settings, but there are challenges there too. So it's become increasingly expensive. So originally that would have been under 100,000, 50,000, but still way out of reach for many health systems. And now that price has escalated. So that company has gone public, and in order to get one, it's becoming closer and closer to the cost of a real MRI. And so there is this sort of ethical issue that maybe it starts out as a low cost point of care technique, and then it becomes a company, and it may or may not actually remain cheap for the people who we're thinking of. There may be a US market that they're thinking of, but a global health market that is a better social justice case, but that may not be the company's priority. And so I think that there are some things that could be great in low resource settings, but that doesn't mean that they're getting there. So that really, I think, behooves the academic community to try and keep pushing that sort of global equity issue forward.
I see. Yeah, I was excited to see your Hyperfine poster on ECTRIMS, but it's helpful to hear that from your perspective. And Dr. Saylor?
Yeah, so I mean, I agree with everything Farah has said. We just recently looked into the cost of a Hyperfine, and a non-refurbished machine is almost $400,000 at this point. And so it's really no longer an inexpensive diagnostic. So I have lost a lot of hope in Hyperfine being a solution to access issues. Just in general, in many countries, and I mean, I can speak mostly to Zambia, where I've worked for 7 years, but when I arrived, there were no Zambian neurologists in the country. And so internists had learned neurology from non-neurologists who had learned neurology from non-neurologists. And so the level of neurological care available was just really, really low. And I think it's a pipe dream to think about having non-neurologists diagnose MS, but that doesn't happen in the US, where internists get a lot more exposure to neurology and a lot more training. And I don't think it's reasonable, honestly, to think that that can happen on a large scale in low and middle income countries either. And so to me, the solution is to actually train neurologists and then to train internists to recognize who needs to be referred to the neurologist. So that's my personal opinion. I know you mentioned that MS is a clinical diagnosis, and it certainly is technically. But even here, where MRIs are challenging to access, I would never feel confident diagnosing someone with MS without imaging. There are so many infectious mimics and so many other things to think about here. And I've been surprised when a young woman comes in with these kind of relapsing symptoms that I'm pretty sure has MS, and then we get the MRI and it's neurocysticercosis or something totally different. And so I never, ever feel comfortable making that diagnosis without an MRI, especially when we're going to start putting people in an environment with lots of endemic infections, including TB, on immunosuppressant medications. And so MRIs are hard to access, but generally with time, people manage the funds that are needed to obtain them, not in a day or a week or sometimes even a month, but usually within a few months that can be done. And then LPs for us, LPs are actually highly stigmatized in Zambia, and that's a whole other talk, but I think briefly it relates to the HIV epidemic and the fact that so many people were dying of HIV before ARVs were available, often from CNS opportunistic infections. And so, and then we know that people present late for care. And so people came in really sick with their cryptococcal meningitis or TB meningitis. They underwent an LP and they died within a few hours, not from the LP, obviously, but from the condition. But the association in the community was that if you have an LP, you die. And so it's very, very challenging for us to get people who need LPs even urgently to have them, let alone as sort of an elective LP. And then the other thing is, oligoclonal bands are not straightforward, right? They're not a quick point of care, yes, no. And so I also, even when we do get LPs and we get oligoclonal band results, I'm very cognizant that the person in the lab that did that may do that 2 or 3 times a year. And so the accuracy of those results are also really, really challenging for me to interpret. So LP is not a standard part of my practice in diagnosing MS. I'll do it if I'm worried about ruling out a mimic, but for the most part, if the MRI is classic and the history is classic, I don't proceed to LP.
I see. Yeah, thank you for that. I didn't know there was a stigma behind LP, so thank you for educating us. And Dr. Diaz?
Yeah, so I agree with what Farah and Deanna both said. I think I can mostly speak for Peru, which is where I've done most of my work since 2019. So Peru, I think, is a bit different from sub-Saharan Africa in that there are many neurologists, but the large majority of them are in the capital city. Actually, 80% of all neurologists are in the capital city. Which is where 1/3 of the population lives, but the other 2/3 of the population live, outside of the capital. So there are very, very few neurologists that are available to people that live outside of the capital city, and transportation to get to the capital city is very cost prohibitive. So I think the reality is that, although there's a lack of awareness of multiple sclerosis on the part of primary care doctors and internal medicine physicians, but also there isn't the ability to be able to realistically refer to neurologists to make the diagnosis if they live outside the capital city. And then even within Lima, it's still a neurologist visit would be covered by the government health insurance, but there are very long wait times, as you can imagine. So it is definitely a barrier, as you've mentioned. And then I agree with Deanna. I think that although you can diagnose MS clinically, as you've highlighted in your talk, there's always the fear of infectious etiologies that may be the cause of the patient's symptoms. So starting immunosuppression is always a worry. Particularly, everybody always jumps to the diagnosis of TB as a possibility. So I think even without access to MRI, I would personally, and I think many of my colleagues in Peru also feel the same way, we wouldn't start immunosuppression empirically, even if it's, a typical case of 2 clinical attacks, and the profile of the person fits with MS. I think a lot of people would be very hesitant to start immunosuppression. And then I agree with Deanna as well. LPs, oligoclonal bands are very cost prohibitive in Peru as well. They actually cost about $300 to $400, which is more than the median salary of somebody in Peru, a monthly salary. So it's very cost prohibitive, and I agree there are a lot of laboratory technical difficulties that kind of muddy the interpretation of the lab tests. So it's typically not done either. So I think overall, we really do need to improve diagnostics and access to diagnostics in a way that everybody would be able to access. But getting there, I think, is tough. So.
I see. Yeah, thank you for that. And it's a humble reminder to think about differentials that you may not see in other places like infections. So I think you and Dr. Saylor already answered my next question is, do you treat people who don't have a certain diagnosis? So thank you for kind of reading my mind. And Dr. Amezcua?
Yeah, I mean, it's amazing to hear all of this, and the truth is that it is true. Just across, for example, in Latin America, the lack of accessibility to MRI, the lumbar puncture, particularly the illegal clonal bands. My understanding is that in some countries too, within Latin America, the issue of IgG synthesis is taken much more as an indicator that there could be some demyelination. Focusing here, because we do have an issue in the US as well, is that we have a problem with access to neurologists overall. And you've heard, of course, probably of the neurology deserts, MS care deserts. Working with the National MS Society, we presented at ACTRANS and CMSC regarding, what are the characteristics, of these neurological and MS care deserts. And it is outstanding to find that almost 200,000 people with MS cannot reach a specialist. And so we have a problem too here, that despite being a, amazing country and having all this accessibility, we don't have access to neurologists. And in many cases, all of them are having problems with, having to drive over an hour to get to a neurologist. And so certainly that is a barrier to the diagnosis and treatment of many of our patients. And we see this even though we live in Los Angeles, Bakersfield and Lancaster and all of those regions, we're talking about 50, 60 miles away, and that is a barrier on its own. And of course, we've already talked a bit about the fact that most primary care, individuals have the ability to refer, but not necessarily will be making a diagnosis. And so that on itself, it's a barrier. In terms of accessibility to MRI, in the low research settings, there is access to MRI, but in many cases, it may be a very low Tesla, right? So the quality is very low, but in most cases, I would say you have access to 1.5. What it comes down to is that there could be an issue of copays. And sometimes the copays could just be astronomical. And for many families and, patients, this is a big issue. And there is sometimes where we have to delay, for example, instead of getting an MRI once a year, we might delay it for every 2 years if that is an issue. But in terms of the diagnosis, of course, we are at least going to try a 1.5 Tesla to get that available.
I see. Yeah. Thank you for that. Are we good with time, Dr. Kip, or?
9 minutes.
9 minutes. Maybe I'll combine the rest of the questions into one in a very selfish way. I had a question about NMO and MOGAP, but maybe we'll skip that one. And then treatment, I think we've briefly talked about, but I think this was one thing I really wanted to hear from you all, if it's all right. So I think reflecting back in your practice in many different settings, including, like you said, in academic institutions, as well as low resource settings globally and locally, do you think your practice in the US has changed? And like, for example, are you more conservative about ordering such things, cognizant of the social determinants of health or health disparities or accessibility issues? And if so, how? Or is it vice versa, that you would, in case, like advocate for more tests for more accurate diagnosis of MS? And then I'm going to combine that with the last question, which is there are a lot of trainees here in the room. So if you have any advice for current neurology residents, med students, or fellows who are interested in going into this field, do you have any general advice, especially when it comes to fellowship options? Like, I know Dr. Saylor, you just started one of the first global neurology fellowships at Hopkins, and Dr. Diaz, you've done the NIH Fogarty Fellowship. And once you become a faculty, in terms of funding to continue this important flavor of research, what are some advices that you might have? So I know that's a very long question, but advice and global versus local practice. So maybe I can start with Dr. Amezcua.
Yeah, absolutely. Well, I would say absolutely. It has changed over time. And I think one of the biggest things that focusing today is to, yes, consider those social determinants of health from the perspective of the patient, but also in the system that you are working in. So for example, what is the system? So if you're within Kaiser, things can be very easy, right? Everything is accessible and every patient. And so it's going to come down to the patient. But if you are in a low resource setting, but even within the private practice, sometimes we don't know what the patient is going through, and or the copays that they're having to pay, even though they have insurance. And so I think we need to be sensitive to their economic stability, to their level of education, so we can educate and be able to say, hey, we are making a shared decision, right, on the issue of how we are treating their MS, where we both feel that we are going to attain the primary goal of obviously of less disability, but also quality of life. So I think those are really important things to consider. That is not just, us making the decisions. We really need to consider the patient, their insurance, the system that we practice and what's accessible and available. That being said, it is important too to be an advocate, right? So within the system, if we understand what can get a treatment that is not yet available there and accessible by being part of committees, developing collaborations with the stakeholders at top will be important. That's something that we've done with the LA County, is that basically we understood that there was no specific, all the FDA treatments that are available for MS, but we can use the off-label use of, for example, of rituximab. And we started using that many years ago, about 20 years ago or so. We were using rituximab. And so because we knew that this was cheap, but it could also have an effect in their disease stability. And so moving forward is basically recognizing, for example, policies that exist, that, for example, 340B pricing is something that could be useful to, basically, come to not maybe collaboration with the pharmaceuticals to say, okay, this medication can be placed on the formulary by decreasing the percentage of the cost. So those are things that we still need to do. And then, of course, at higher levels is advocating, with Congress and to make sure that we at least have access to the treatments. At least, there's the World Health Organization of 3 treatments. And so that is something that at different countries needs to be put into place. And so yes, being an advocate is important. Making, patient and physician shared decision-making is important, and learning the systems that we are working in.
Yeah, thank you, Dr. Amezcua. And it was nice to see Nouriel at the Neurology on the Hill. So I completely agree.
Absolutely. He is the main person that I'm relying on.
Yeah, thank Thank you very much. And Dr. Saylor, maybe perhaps due to the interest of time, I would love to hear your advice for trainees, especially pertaining to the fellowship that you've designed, and as a faculty member moving forward, what are some ways that we can think about funding, et cetera?
Yeah, I mean, these are great questions. I think from a trainee perspective, especially as a student or a resident, you know, the first step is just gaining experience and going to a low resource setting. And I think you choose that setting either based on a region, if there's a particular region that you're really interested in working in, or a condition. You know, I ended up in sub-Saharan Africa because of my interest in neuro-ID. So I think you choose a region and then find a place where you can go have I think an appropriately mentored experience, because you also don't want to get into a situation where you're somewhere being asked to practice outside of your scope in a foreign healthcare system that you don't know. And so a lot of that is just making connections. You know, the global neurology world is still really, really small. And so reaching out to any of us, I think, even if we're not the right one to facilitate what you want, we probably know the person who is the right one. And so I think just making connections, going and having an experience. My personal philosophy is that your first experience should really be a clinical experience where you really embed yourself in the healthcare system and understand the epidemiology and the challenges before you jump to doing research in a population. But then, you know, if you find that you've done that and that's something of interest, there are an expanding number of options for funding. So you mentioned the Fogarty, you mentioned the Global Neurology Fellowship at Hopkins. Serena Sputich has a Global Health Fellowship at Yale. And so there are an expanding number of options. And again, I think it's finding a mentor who's sort of navigated this and can help guide you. And then as faculty, you know, there's certainly options for global health funding. I think all of us on this call have managed that. The options are fewer, but they're there, and it's just a matter of persistence and seeking them out. And again, the key is mentorship, finding someone who's sort of navigated that and can provide guidance on what options are there.
I see. Got it. Yeah, thank you, Dr. Saylor.